Bismillahirrahmanirrahim. Now we have granulosa cell tumors, pathogenesis, sex coat stromal tumor, increased estradiol and increased inhibin. The clinical features are complex ovarian mass. Juvenile subtype is precocious puberty. Adult subtype include breast tenderness, abnormal uterine bleeding, and post-menopausal bleeding. Histopathology. On histopathology, we'll find colexner bodies, cells in the rosette pattern, and management is endometrial biopsy, endometrial cancer, and surgery, that is tumor staging. Post tumor staging. Choriocarcinoma. It is a form of gestational trophoblastic neoplasia. It typically presents less than 6 months after pregnancy. Presentation is irregular vaginal bleeding, enlarged uterus, pelvic pain, pulmonary metastasis like chest pain, hemoptysis, and dyspnea. Diagnostic test is quantitative beta HCG. Staging is chest X-ray. CT scan is insignificant in choriocarcinoma's staging. So choriocarcinoma, the risk factors are advanced maternal age, prior complete hydatidiform mole, presentation is amenorrhea or abnormal uterine bleeding, pelvic pain or pressure, symptoms from metastasis like lung, vagina, uterine mass, elevated beta HCG level, and treatment is with chemotherapy. So with the choriocarcinoma, the beta HCG level will be high. With the with the granular cell tumor, estradiol and inhibin level will be high, and other ones have been discussed in the previous session. Then we have rectovaginal fistula. It is an abnormal connection between the rectum and the vagina. A fistula is basically the abnormal connection between the two luminal cavities. Most common cause is obstetric injury, present within first 2 weeks postpartum. Most commonly occurs after third or fourth degree laceration. Okay, inadequate wound repair, wound breakdown, and infection. In less industrialized country, it occurs due to poor intrapartum care, prolonged second stage of labor, fetal head compression, ischemic pressure, that is necrosis over rectovaginal septum. Presentation: malodorous brown tan discharge from the vagina. Diagnosis is dark red, velvety red mucosa on posterior vaginal wall on visual examination. Do anoscopy if the fistula is not visualized but is highly suspected. Treatment: surgical repair. Then we have vesicovaginal fistula. It is an abnormal connection between the vagina and the urinary bladder. So the risk factors for development of vesicovaginal fistula is pelvic surgery, pelvic irradiation, prolonged labor or childbirth during trauma, or genitourinary malignancy. Clinical features are painless, continuous urine leakage from vagina. Diagnostic study is physical examination, dye test, and cystourethropy. Then what is cervical cancer? The risk factor for development of cervical cancer are infection with the high-risk HPV strain 16 and 18, history of sexually transmitted diseases, early onset sexual activity, multiple or high-risk sexual partners, immunosuppression, oral contraceptive use, low socioeconomic status, and tobacco use. Oral contraceptive use, low socioeconomic status, tobacco use, and HPV means human papilloma virus. So most commonly, the people who have cervical cancer, they are asymptomatic. If symptomatic, presentation is vaginal discharge, postcoital or intramenstrual bleeding, and cervical lesion. Diagnosis is done with the pap testing, colposcopy. Endocervical curettage is done in cases of unsatisfactory colposcopy. For example, squamocolumnar junction not completely visualized. Then this is a table about cervical cancer. Risk factor is immunocompromised. For example, the women who have HIV. If you have HIV, cervical cancer can occur in months. Otherwise, it takes like 10 years or something for the cervical intraepithelial neoplasia to convert into cancer. Early onset sexual activity, multiple or high risk sexual partners, without using barrier methods or condoms, previously sexually transmitted infection, and tobacco use. Pathogenesis is HPV infection type 16 and 18. They are high risk types. Clinical manifestation is asymptomatic postcoital or intermenstrual bleeding, increased vaginal discharge, inguinal lymphadenopathy, pelvic or low back pain. Diagnosis is with cervical biopsy or colposcopy. Then this is another table, pretty much the same table about the cervical cancer. So the risk factors are immunocompromised, early onset sexual activity, multiple high risk sexual partners, previously transmitted infection and tobacco use, pathogenesis 16-18 types. Cervical clinical manifestations are mostly asymptomatic but postcoital or intermenstrual bleeding. increased vaginal discharge, inguinal lymphadenopathy, cervical, pelvic or low back pain, and diagnosis is cervical biopsy on colposcopy. Then this is a picture of progression of cervical cancer. Carcinoma in situ, it looks something like this when we apply acetic acid. Early stage is like this, and advanced stage is this, like this area is involved in this, and okay. Then we have management of CIN3, management of cervical intraepithelial neoplasia 3, age more than 45 and not currently pregnant. Then we have LEEP, cold knife conization. LEEP means loop electrostatic excision procedure. Cold knife conization and cryoablation can be done. Pap test with HPV 1 and 2 years post procedure. Management of non-invasive cancer is based on surgical margins. Positive surgical margins, so repeat conization if fertility needs to be preserved. Hysterectomy if no future fertility is desired. Negative surgical margins, repeat PAP and HPV testing, HPV co-testing at 1 and 2 years. Then we have the next topic, that is cervical cancer in HIV positive patients. In HIV positive patients, cervical cancer is an AIDS defining illness because it indicates severe immunocompromise. In immunocompromised patient, HPV can cause cervical dysplasia that rapidly progresses to cancer. For this reason, HIV positive patients require cervical cancer screening, for example, PAP testing, at the time of HIV diagnosis, followed by close interval repeat testing, for example, in 6 to 12 months. Okay, then just give me a second. Primary ovarian insufficiency. So it is a early version of menopause. So the primary ovarian insufficiency means clinical features include that amenorrhea at age less than 40, hypoestrogenic symptoms like hot flashes, increased FSH will be there, and estrogen will be low. Major causes are Turner syndrome 45XO, Fragile X syndrome, FMR1, Fragile X, mental retardation 1, also in females, autoimmune oophorytis, anti-cancer drugs, pelvic radiation, and galactosemia. Management is estrogen therapy with progestins if intact fetus. Hypergonadotropic hypogonadism in the women aged less than 40 is known as hypergonadotropic hypogonadism, which means FSH and GnRH level will be high, but still there is hypogonadism in the women aged less than 40 is known as primary ovarian insufficiency. The diagnosis is increased FSH and increased LH. Treatment is hormone replacement therapy, menopausal symptom release and bone loss protection. Cryopreservation techniques are used for fertility preservation. Like you freeze your ovum or sperms and then you can use them later on. Differentials include hypothalamic amenorrhea. Patients with hypothalamic amenorrhea do not have vasomotor symptoms even though they have low estrogen levels. Diagnostic findings of amenorrhea. So in ovarian failure, FSH, LH, FSH is high, LH is high, prolactin and TSH are normal. Functional hypothalamic amenorrhea, FSH and LH are low, prolactin and TSH are normal. In Asherman syndrome, FSH, LH, prolactin and TSH are all normal. Prolactinoma, FSH and LH are low, prolactin is high and TSH is normal. Hypothyroidism, FSH, LH is low and prolactin and TSH are going to be high. Increased TRH, thyroid releasing hormone, increased prolactin, that will result in increased GnRH and decreased LH and FSH. Then we have hypothalamic amenorrhea. Exercise induced hypothalamic amenorrhea. The clinical presentation is strenuous exercise, relative caloric deficiency, stress fractures, amenorrhea, and infertility. Hormone levels include decreased GnRH, decreased LH and FSH, and decreased estrogen. Long-term consequences are decreased bone mineral density, increased total cholesterol, and increased triglycerides. Treatment is increased caloric intake, estrogen, and calcium and vitamin D. Progestin challenge test can be done to confirm the low estrogen levels and no shedding. Pathophysiology of functional hypothalamic amenorrhea. Excessive physical training, very low calorie diet, starvation, weight loss, chronic illness, stress and depression, and anorexia nervosa. That will lead to increased ghrelin. NPY, what is that? NPY means neuropeptide Y. CRH means corticotropin releasing hormone, GABA and beta endorphins, and decreased leptin. That will lead to decreased GnRH production from the hypothalamus, and resultant pituitary will produce decreased level of LH and FSH, and ovaries will produce decreased level of estrogen. That will result in amenorrhea, low estrogenic state, and bone loss. Primary ovarian insufficiency in Fragile X syndrome. Common in patients who are Fragile X metal retardation 1 gene premutation carrier, those with 50 to 200 CGG repeats. Associated features are neurobehavioral clinical features, generalized anxiety disorder, autism, family history of Fragile X syndrome. Mechanism: this premutation causes FMR1 mRNA overexpression, cytotoxic effect on ovarian primordial follicles, and accelerated follicle depletion. Women with ovarian failure at age less than 40 and no other obvious cause of primary ovarian insufficiency are tested for FMR1 gene mutation. Then the next topic is endometritis. So it's endometriosis. Endometriosis is implantation of endometrial tissue outside the uterus. So it can form an endometrioma in the ovary, which is chocolate cyst, implant on the bladder. Then it can implant uterosacral ligament thickening and implants, bowel implants and implants and adhesion on the uterus. Okay. It is a common cause of chronic pelvic pain, CPP. Look for pelvic pain for more than 6 months. Most common complaints are dysmenorrhea, non-cyclic pain exacerbated by exercise. Physical examination are fixed and immobile uterus, rectovaginal nodularity. Diagnosis is on ultrasound. There will be adnexal mass. Homogeneous cystic ovarian mass with internal echoes, for example, ground glass, is highly suggestive of an ovarian endometrioma. Treatment: asymptomatic patients, reassurance and observation. For symptomatic patients, medical or surgical, that is listed in the table. Indications for treatment and endometriosis: chronic pelvic pain, dysmenorrhea or increasingly worse lower abdominal cramping throughout menses that is unrelieved by NSAIDs, dyspareunia and infertility. Differentials are as follows: epithelial ovarian tumor, mature teratoma, and chronic pelvic inflammatory disease. Differentiating points are: ultrasound shows septated mass with solid components. Ultrasound shows calcifications and hyperechoic nodules. It can cause chronic pelvic pain and infertility, same as endometriosis. What is the meaning of same as endometriosis? We are talking about endometriosis. Okay, actually, I was just a bit swayed away. I'm sorry. We talked about this table. So the differentials are epithelial ovarian tumor. In epithelial ovarian tumor, ultrasound shows septated mass with solid components. Then mature teratoma is a differential. Ultrasound will show calcification and hyperechoic nodules. And in chronic pelvic inflammatory disease, it can cause chronic pelvic pain and infertility, same as endometriosis. Its complication are tubo-ovarian abscess, appears on ultrasound as thick-walled, multiloculated adnexal mass with air fluid levels and internal debris. Then there is another table about endometriosis. Pathogenesis is ectopic implantation of endometrial gland. The clinical features are dyspareunia, which is painful intercourse, dysmenorrhea, painful menses, chronic pelvic pain, infertility, and dyschezia, which is painful defecation if it is implanted on the rectum or in the pouch of Douglas baby. Physical examination is immobile uterus, cervical motion tenderness, laterally displaced cervix and anatomic distortion, adnexal mass, rectovaginal septum, posterior cul-de-sac, and uterosacral ligament nodule. Diagnosis is direct visualization and surgical biopsy. Laparoscopic diagnosis and therapeutic. So laparoscopy is diagnostic as well as therapeutic modality of choice. Treatment is medical, oral contraceptive and NSAIDs, and surgical resection. Management of endometriosis. Suspected endometriosis on the basis of chronic pelvic pain, dysmenorrhea, deep dyspareunia, and dyschezia. Contraindications to medical therapy like hypercoagulability, oral contraceptive pills, need for definitive diagnosis, history of infertility, so it's already causing problem, concern for malignancy or adnexal mass. If these things are not present, give NSAID with or without oral contraceptive. If these are present, do the laparoscopy. Okay. Then we have PCOS, that is polycystic ovarian syndrome. Too much estrogen from fat, negative feedback on hypothalamic pituitary axis, no LH surge, no ovulation. So makes sense. First line is weight loss. So decrease estrogen from fat, androgens, back to cycle. Actually, it is a bit wrong. Uh, Estrogen, I think these are the androgens, not estrogens themselves. Okay. There is something odd with this statement because too much estrogen from, it's not estrogen that is coming from fat. There are too much androgens which are coming from the fat, and then those androgens have a negative feedback on the HPA somehow. Okay, I don't remember the loop of that, but these are not estrogens. These are androgens which are causing virilization and masculinization of the woman. Okay, so the PCOS clinical features are androgen excess, acne, male pattern baldness, hirsutism, oligoovulation or anovulation, for example, menstrual irregularities, obesity, and polycystic ovaries on ultrasound. Pathophysiology is increased testosterone level, increased estrogen level, LH and FSH imbalance. Comorbidities are metabolic syndrome like diabetes and hypertension, obstructive sleep apnea, non-alcoholic steatohepatitis, and endometrial hyperplasia or cancer. Treatment options are weight loss, which is first line, oral contraceptives or menstrual regulation, clomiphene citrate or ovulation induction. Ovulation inducers are clomiphene or letrozole, which are aromatase inhibitors. Letrozole is aromatase inhibitor, so decreases the conversion of estrogen from fat. So no HPA suppression, LH is back with the surge and ovulation. Okay. Absolute contraindication to combine hormonal contraceptive. Migraine with aura, more than 15 cigarettes per day plus age more than 35. Hypertension more than 160 by 100 millimeters of mercury. Heart disease, diabetes mellitus with end organ damage. History of thromboembolic disease, antiphospholipid antibody syndrome, history of stroke, breast cancer. Never give any hormonal contraceptives in breast cancer. Risk present cancer, risk or present cancer. Mostly copper IUD is the best in these situations. Cirrhosis and liver cancer. Major surgery with prolonged immobilization and use of less than 3 weeks postpartum. Okay, so use less than 3 weeks postpartum is also contraindicated. Some reason. Tubo-ovarian abscess. It is a complication of pelvic inflammatory disease. Features are fever, abdominal pain, abnormal discharge, cervical motion tenderness. Diagnosis is lab findings include increased CA125, increased C-reactive protein, and leukocytosis. Pelvic ultrasound is complex, thick-walled, multi-loculated adnexal mass with air fluid levels and internal debris. Pelvic inflammatory disease treatment. Inpatient treatment is IV ceftriaxone or cifotecan with oral doxycycline, IV clindamycin with gentamicin. Outpatient treatment, for example, IM ceftriaxone with oral doxycycline. Add metronidazole if pelvic inflammatory disease is complicated by tubo-ovarian abscess. Estrogen progestin contraceptive benefits and risks. So the benefits are pregnancy prevention, endometrial and ovarian cancer risk reduction, menstrual regulation, for example, anovulation, dysmenorrhea, and anemia. Hyperandrogenism treatment, for example, hirsutism and acne. The risks are venous thromboembolism, hypertension, hepatic adenoma, stroke, and myocardial infarction, both very rare, and cervical cancer. Endometrial cancer risk decreases because of progestins counteracting estrogen. Ovarian cancer risk decreases because of decreased ovulation, decreased risk in pregnancy. Oral contraceptives profile, OCP's profile, so benefits, okay, a lot of them. So benefits are pregnancy prevention, endometrial and ovarian cancer risk reduction, menstrual regulation, for example, anovulation, dysmenorrhea, and anemia, and hyperandrogenism treatment. Side effects include breakthrough bleeding, breast tenderness, nausea, and bloating, hypertension, venous thromboembolism disease, increased risk of cervical cancer, liver disorders, for example, hepatic adenoma, increased triglyceride due to estrogen component, and stroke, MI, very rare. Absolute contraindications are migraine with aura, more than 15 cigarettes per day plus age more than 35, hypertension more than 160 millimeters of mercury, heart disease, diabetes with end organ damage, history of thromboembolic disease, antiphospholipid antibody syndrome, thrombophilia vector 5 Leiden, history of stroke, active breast cancer, cirrhosis and liver cancer, active hepatitis, major surgery with prolonged immobilization and use of less than 3 weeks postpartum. The relative contraindication is mild or medication controlled hypertension, age more than equal to 35 plus smoking less than 15 cigarettes per day, certain medication like lamotrigine and rifampin, inherited thrombophilia carrier and family member with thrombophilia plus thromboembolism, hypertension due to increased angiotensin synthesis by estrogen during hepatic first pass metabolism, venous thromboembolism due to hypercoagulable properties of estrogen. Then, if a woman is having migraine during pregnancy, so what is the therapy for that? Okay, it's not in pregnancy, we are not doing OBS, we are doing gynae, I'm sorry. So the therapy for migraine is abortive therapy is triptans, NSAIDs. We are not supposed to give them in pregnancy because they can specifically not in the third trimester because they can cause the premature closure of the ductus arteriosus. So NSAID and acetaminophen otherwise can be used for migraine therapy. Antiemetics and ergotamine, preventive anticonvulsant like topiramate or valproate, beta blockers, antidepressant like tricyclic or venlafaxine. Abnormal uterine bleeding on oral contraceptive pills. Abnormal uterine bleeding on oral contraceptives. So in cycle 1, there is endometrial thickening, oral contraceptives, and then we have withdrawal bleeding, in the last 7 days when the woman is taking placebos. In cycle 2, there is more thickening, and cycle 3, like there is hyperplasia going on. So what is the meaning of that? Basically, abnormal uterine bleeding on oral contraceptive pills. All I know is that oral contraceptive pills decrease the risk of abnormal uterine bleeding. So what is the meaning of this diagram? It means something which I don't know. I actually have no idea that what is the meaning of this diagram, but we'll see that later on sometimes maybe. Okay, now moving forward, emergency contraception. Emergency contraception, copper containing intrauterine device. Timing after intercourse 0 to 120 hours. Efficacy is more than 99%. Contraindications are acute pelvic infection, severe uterine cavity distortion, Wilson's disease, because Wilson's disease is a disease of copper excess, complicated organ transplant, failure, Bristol 0 to 120 hours, 98 to 99%, and the contraindications are not present. Levonorgestrel, timing after intercourse is 0 to 72 hours, efficacy is 59 to 94%, and there is no contraindication. And oral contraceptives, timing after intercourse is 0 to 72 hours, efficacy is 47 to 89%, and again there is no contraindication. Combined estrogen progestin oral contraceptives containing levonorgestrel or norgestrel. So management of migraine in pregnancy, non-pharmacological therapy, that is rest, hydration and heat, acetaminophen, antiemetics, for example promethazine, codeine, caffeine and butalbital, non-steroidal anti-inflammatory drugs, for example naproxen, and opioids, for example oxycodone. Emergency contraception methods. Number 1 is copper intrauterine device. Mechanism: copper causes inflammatory reaction that is toxic to sperm and ova and impairs implantation. Time after intercourse 0 to 120 hours, and efficacy is 99%. Then second line is Bristol pill. It is anti-progesterone, delays ovulation. Time course is 0 to 120 hours and efficacy is more than 85%. Levonorgestrel pill, its third line, progesterone, delays ovulation. Time course is 0 to 72 hours and efficacy is 85%. And oral contraceptive pills, it is the last and the worst. Progesterone, delays ovulation 0 to 72 hours and its efficacy is the least, that is 75%. Then we have vaginal cancer. Vaginal bleeding, malodorous discharge, ulcerated vaginal lesion. So there will be the clinical features include vaginal bleeding, malodorous discharge, ulcerated vaginal lesion, which will be an irregular flag located in the upper third of posterior vagina. Features of metastatic disease, include pelvic pain, urinary symptoms like hematuria, and bulk symptoms, for example, constipation. Diagnosis done with the biopsy to evaluate the depth of invasion. Management, non-invasive cancer, we do the topical therapy and wide local excision. For the invasive, we do the surgery, radical hysterectomy, vaginectomy, pelvic node dissection, and chemoradiation. Differentials include atrophic vaginitis, no ulcerated regions are seen. Vaginal cancer risk factor age more than 60, human papilloma virus infection, tobacco use, in utero diethyl pistol exposure, clear cell adenocarcinoma only. The clinical features include vaginal bleeding, malodorous vaginal discharge, and irregular vaginal lesion. Diagnosis is by vaginal biopsy, and management is surgery with or without chemoradiation. Desquamative inflammatory vaginitis, presentation, copious body discharge and inflamed erythematous vagina. Diagnosis is with wet mount, predominant leukocytes, and treatment is with topical corticosteroids. Tamoxifen, estrogen receptor antagonist in the breast and agonist in the uterus and bone. So tamoxifen is basically estrogen receptor modulator. So estrogen receptor antagonist in the breast and agonist in the uterus and bone. Antagonist in the breast means it prevents the breast cancer, and agonist in the uterus means excessive endometrial proliferation. Endometrial polyps and premenopausal women. It can cause endometrial polyps in the premenopausal women because there is excessive endometrial proliferation and endometrial hyperplasia and cancer in the postmenopausal women. So, while treating the breast cancer with tamoxifen, we have to take this thing in consideration. Agonist in the bone, it increases the bone density. Indication in premenopausal women who are at low risk of breast cancer recurrence and prevention of breast cancer in high risk patients. It's also second line endocrine adjuvant agent for the postmenopausal women who cannot use aromatase inhibitor therapy. It also acts on the CNS and have an anti-estrogenic effect leading to thermoregulatory dysfunction and hot flashes. It also increases the blood lipid profile. Then we have selected estrogen receptor modulators, SERMs. The drugs are tamoxifen and raloxifene. Mechanism of action is competitive inhibitor of estrogen binding, mixed agonist and antagonist action. Indications are prevention of breast cancer in high-risk patients, tamoxifen adjuvant treatment of breast cancer, and raloxifene is for the postmenopausal osteoporosis. Adverse effects include hot flashes, venous thromboembolism, endometrial hyperplasia, and carcinoma that is associated with the tamoxifen only. Secondary amenorrhea, it means that the woman previously had normal menstrual cycle, and now, due to some reason, she started to have amenorrhea. So, the secondary amenorrhea is defined as cessation of previously established menses for more than 3 months and cessation of irregular menses for more than 6 months. Secondary amenorrhea evaluation. If it is secondary amenorrhea, check for the beta HCG level. If that beta HCG comes out to be positive, it is because of pregnancy. If it is negative, now we have quite a few possibilities. Check for the prolactin level. If it is more than 200 in prolactinoma, increased prolactin TSH is normal. It is pituitary adenoma. Then increase in FSH, primary ovarian insufficiency, hormones normal prior to uterine procedure, Asherman syndrome, increased testosterone, then it can be PCOS, increase in TSH, it is hypothyroidism. So infertility due to the pelvic inflammatory disease. So these are the type of lesions which can form in pelvic inflammatory disease. So the pelvic inflammatory disease has symptoms of lower abdominal pain and abnormal bleeding. Risk factor are multiple sexual partners, age 15 to 25, previous pelvic inflammatory disease, inconsistent barrier contraception use, partner with sexually transmitted infection. Physical examination is fever more than 38.3, more than 100.9 degree Fahrenheit, cervical motion tenderness and mucopurulent cervical discharge. Treatment outpatient with ceftriaxone plus doxycycline and inpatient with cefoxitin plus doxycycline. Complications are tubo-ovarian abscess, infertility, ectopic pregnancy, and perihepatitis. Presentation: fever, lower abdominal pain which worsens with menses, mucopurulent cervical discharge, cervical motion tenderness, uterine tenderness, intermenstrual spotting due to cervicitis. The risk factors are age less than 25, sexual activity without barrier contraception. Complications include ectopic pregnancy, tubo-ovarian abscess, and infertility. Indications for hospitalization for the pelvic inflammatory disease are pregnancy, failed outpatient treatment, inability to tolerate oral medications, non-compliant with the therapy, severe presentation, for example, high fever and vomiting, complications like tubo-ovarian abscess and perihepatitis. Then we have perihepatitis or Fitz-Hugh-Curtis syndrome. It is associated with the vomiting, increased transaminases, and right upper quadrant pain, which increases on aspiration. Pelvic inflammatory disease, the symptoms are lower abdominal pain and abdominal bleeding. Physical examination are cervical motion tenderness, fever of more than 38.3 degrees Celsius or more than 11.9 degree Fahrenheit, mucopurulent cervical discharge. Treatment: third generation cephalosporin with azithromycin or doxycycline. Complications are tubo-ovarian abscess, infertility, ectopic pregnancy, and perihepatitis. Then we have intrauterine adhesions related to Asherman syndrome if amenorrhea. Okay, so intrauterine adhesion, the risk factor that infection like septic abortion or endometritis, intrauterine surgery like curettage or myomectomy. The clinical features are abnormal uterine bleeding, amenorrhea, infertility, cyclic pelvic pain, and recurrent pregnancy loss. Evaluation is done with a hysteroscopy. And if this is intrauterine adhesions are associated with amenorrhea, this can be because of Asherman syndrome. And Asherman syndrome is a condition in which there is amenorrhea because of excessive loss of endometrium during the dilation and curettage. Then we have urethral prolapse. So urethral prolapse. Okay, so urethra is prolapsing downwards. This is clitoris, urethra, labia majora, vagina, and labia minora, and this is a prolapsed urethra, circumferential tribal lesion. Acute cervicitis, most commonly because of Neisseria gonorrhea and Chlamydia trachomatis. Features include mucopurulent cervical discharge, tribal cervix that bleeds with manipulation. Diagnosis is gold standard in cases of acute cervicitis is nucleic acid amplification test. On light microscopy, no organism is found because chlamydia is obligate intracellular organism. Then we have labial adhesions. So normally vagina should look something like this. Like this is urethra, labia minora, and vaginal opening. But if there is an adhesion, that is partial labial adhesion downwards, so it looks something like this. Causes: low estrogen production, common in prepubertal girls, age 2 to 3. Chronic inflammation, like poor hygiene, infections, for example, vaginitis, irritation like diaper rash, trauma because, for example, saddle injury and sexual abuse. Adhesions can be partial or complete. Partial adhesions are generally asymptomatic, but some children may develop pain or pruritus, which can lead to secondary excoriations and exacerbate adhesion development. Adhesions covering the urethral meatus can lead to following: abnormal urinary stream and increased risk of UTIs due to urine accumulation. Treatment: if it is asymptomatic, then no treatment is required, and if it is symptomatic, then we can give topical estrogen. Then we have vaginitis and its differentials. These three things, you must remember these three bugs. They will come every time we are talking about vaginitis. The first one is bacterial vaginosis, that is caused by the Gardnerella vaginalis. Then trichomoniasis, which caused by Trichomonas vaginalis, and Candida vaginitis, which is caused by Candida albicans. So let's talk about them one by one. The preterm risk and premature rupture of membrane risk. So with these conditions, we have a risk of preterm birth or premature rupture of membrane. Examination for bacterial vaginosis will have a thin off-white discharge with fishy odor and no inflammation. Lab findings will show a pH of more than 4.5, blue cells, positive whiff test, amine odor with a KOH. Treatment is with the metronidazole or clindamycin. Trichomoniasis, that is Trichomonas vaginalis, on examination they will be thin, yellow-green, malodorous, frothy discharge. There will be vaginal inflammation. Lab findings will show a pH of more than 4.5 and motile trichomonads. Treatment is metronidazole, and also you should treat the sexual partner. Then Candida albicans, there is thick cottage cheese discharge and vaginal inflammation. Normal pH will be less, that is 3.8 to 4.5, and pseudohyphae will be seen. So in Gardnerella and Trichomonas, the pH is unaltered, it is more than 4.5. But in the case of Candida, it becomes acidic or less than 4.5, even more acidic than it is already. And pseudohyphae, and the treatment is fluconazole. Then we have vulvovaginal candidiasis. So it looks something like this: a reddened, inflamed vulva, and white curd-like discharge. Risk factors are diabetes mellitus, immunosuppression, pregnancy that is staged with increased estrogen, oral contraceptive pills and antibiotic use, presentation is white vaginal discharge, vulvovaginal pruritus, dysuria and vaginal erythema and excoriations, diagnosis, normal pH, budding yeast and pseudohyphae on microscopy, women with recurrent vulvovaginal candidiasis infection more than 4 episodes in a year, and other signs of diabetes like nocturia and urinary frequency should be evaluated with the hemoglobin A1C. Treatment is fluconazole. Bacterial vaginosis. The clinical features: thin, off-white discharge with fishy odor, no vaginal inflammation. Lab findings are pH more than 4.5, blue cells, positive whip test, amine odor with potassium hydroxide. Treatment is metronidazole or clindamycin. Complications: increased risk of preterm birth, increased risk of acquisition of HIV, herpes simplex virus type 2, gonorrhea, chlamydia, and trichomonas infections. What is EMSEL's criteria? It includes 4 points. If the patient has 3 out of 4, she is diagnosed with a bacterial vaginosis. That is homogeneous vaginal discharge, pH more than 4.5, blue cells on microscopy and positive whip test. Obesity and anovulation, effect of anovulatory cycles on endometrium. So hormone level is this, so it is like pretty much the same. Every time endometrial proliferation occurs, if there is anovulation, in cycle 2 there is hyperproliferation and in cycle 3 there is heavy bleeding. Okay, so mechanism in which obesity can lead to anovulation is obesity causes increased insulin resistance and hyperglycemia that leads to decreased sex hormone binding globulin and increased free androgen, increased aromatization in the adipose tissue to estrone, and there will be increase in estrone level. High estrone level affects the GnRH pulses at the level of hypothalamus. It results in high frequency, short level GnRH pulses. These pulses preferentially produce LH. Imbalance in LH and FSH, there will be lack of LH surge and anovulation and abnormal uterine bleeding. So this is the mechanism of PCOS as well. You must remember this. Treatment is weight loss and oral contraceptive pills. Obesity and ovulation, androstenedione in adipose tissue via aromatase is converted into estrone. Estrone inhibits the hypothalamus to produce GnRH and anterior pituitary will decrease production of FSH and LH, but this is not just the case. The thing is that high estrone level affects the GnRH pulses at level of hypothalamus such that it results in high frequency short interval GnRH pulses, and these pulses preferentially produce LH. Imbalance in LH and FSH lead to lack of LH surge, anovulation and abnormal uterine bleeding. Okay, so this will lead to ovary to decrease the production of estradiol, and resultant there will be anovulation and amenorrhea. Then we have hidradenitis suppurativa. So it looks something like this. It is pitted acneiform scars. These are fibrotic bands and keloid formation, and these are the thickened plaques. It's a chronic inflammatory condition which creates inflamed purulent nodules in the intertriginous area, for example, axilla and inguinal region. Causes spontaneously draining sinuses, scarring and multiple open comedons. Disease is multifactorial and painful. It has a chronic progressive course with recurrences that affect the follicles within the same region. Risk factors are obesity, tobacco use, family history, and treatment is with doxycycline. 5-alpha reductase deficiency. So 5-alpha reductase deficiency, the pathogenesis is 46XY genotype, impaired testosterone to DHT conversion, impaired virilization during embryogenesis, normal male testosterone and estrogen levels will be there. The clinical features are male internal genitalia, for example, testes and vas deferens, female external genitalia, for example, blind ending vagina, phenotypically female at birth, virilization at puberty because of increased testosterone, clitoromegaly, increased muscle mass, male pattern hair development, and nodulocystic acne. Normal male development, male internal genitalia is made by testosterone, and male external genitalia is formed by dihydrotestosterone. If 5-alpha reductase is not there, 5-alpha reductase normally converts the testosterone into dihydrotestosterone. If that is not there, external genitalia won't be formed. Okay, so male internal genitalia, for example, vas deferens and epididymis are made of testosterone, and male external genitalia like penis and prostate are made with DHT. Hence, in patients with this disease, they have normal internal genitalia, but phenotypically they are females with undescended testes. At puberty, testosterone level increases lead to virilization. There will be nodular cystic acne, clitoromegaly, voice deepening, and increased muscle mass. Differentials include androgen insensitivity syndrome. There is no acne or pubic and axillary hair in acute androgen insensitivity syndrome, but they do occur in 5-alpha reductase deficiency. There is no breast development in 5-alpha reductase deficiency as testosterone binds to androgen receptor and inhibits the breast tissue proliferation. Androgen insensitivity syndrome (AIS) pathophysiology is that it is an X-linked mutation in androgen receptor. The clinical features are genotypically male, 46XY karyotype, phenotypically female, breast development, absent or minimal axillary and pubic hair, female external genitalia, absent uterus, cervix, and upper one-third of vagina, and cryptorchid testes. So this is different from that. It is androgen insensitivity syndrome. It is 46XY karyotype, but there is a phenotypic female with breast development and absent axillary or pubic hair, female external genitalia. Management is gender identity, assignment counseling, and gonadectomy, that is malignancy prevention. Androgen insensitivity syndrome, 46XY male, androgen receptor defect. Free testosterone is aromatized to estrogen, resulting in breast tissue development. Cryptorchid testis secretes testosterone, no axillary or pubic hair, and no penis or scrotum, and no uterus or ovaries. Klinefelter syndrome, it is 47XXY condition. There will be intellectual disability, sparse facial or body hair, gynecomastia, infertility, cryptorchidism, long legs. So in Klinefelter syndrome, the pathogenesis is non-disjunction of sex chromosomes resulting in 47XXY male. So non-disjunction is basically when during meiosis, half chromosomes move in, okay, it's not like this. So like if there are 4 chromosomes I'm drawing, so half go in one cell while the other half remain in the other half go in the second cell like this, and there is a division of the cells. But in case of non-disjunction, what happens is that instead of an equal distribution of chromosomes, maybe this chromosome fails to travel to the other cell and there is 40 instead of 46 we have 47 chromosomes, and if it happens at the level of sex chromosomes, so we can have a condition called Klinefelter syndrome. In Klinefelter syndrome, non-disjunction of sex chromosomes resulting in 47XXY male. The clinical features are primary hypogonadism, increasing long bone length, gynecomastia, learning and socializing difficulties. Lab findings will include decreased testosterone, increased LH and FSH due to loss of feedback inhibition, and increased estradiol. What are the indications to do the endometrial biopsy? If age is more than 45, abnormal uterine bleeding and post-menopausal bleeding. For age less than 45, abnormal uterine bleeding with unopposed estrogen, obesity and anovulation, failed medical management, and Lynch syndrome, that is hereditary non-polyposis colorectal cancer, colon, ovarian, and endometrial cancer. Age more than equal to 35, atypical glandular cells on Pap smear. Pap test results requiring endometrial biopsy. Women aged less than 45 with endometrial cells on Pap test has no risk factor for endometrial hyperplasia. Do not require endometrial biopsy, that is fairly common, especially if Pap test was done during the first 10 days of menstrual cycle. Women aged more than 35 with atypical endometrial cells on Pap test needs to undergo colposcopy, endocervical curettage and endometrial biopsy. Patients diagnosed with endometrial cancer need to undergo hysterectomy with salpingo-oophorectomy for the cancer screening and treatment. So what is this about? I have to zoom it in. So they're talking about drugs which act at different levels of hypothalamic pituitary axis, I guess. So this is hypothalamus, and we have GnRH that stimulates the pituitary to produce LH and FSH. Then in the ovary, this FSH and LH, FSH will stimulate the granulosa cells and LH will stimulate the theca cells. Okay, so in ovary, normally progesterone By 17 alpha hydroxylase is converted into androstenedione, that is converted to testosterone, which by the virtue of aromatase is converted into estrogen. And somehow these two hormones are playing their part in this. How come? FSH, the granulosa cells produce androstenedione or testosterone. Yes, they produce it. And theca interna, I guess they produce progesterone maybe or something, but FSH, yes, that is happening for sure. Okay. Then the same thing, progesterone to 7 alpha hydroxylase to androstenedione to testosterone. LH stimulates the Leydig cells, which are going to produce this thing. Okay, testosterone by 5 alpha hydroxylase is converted to dihydrotestosterone, and these things. Now let's see the mechanism of action. The clomiphene, in the presence of low estrogen level, will stimulate the release of GnRH. That is why we use clomiphene citrate for the induction of ovulation. GnRH agonist transient effect during first few weeks of intake. They will increase the level of LH and FSH, but if we give a constant GnRH agonist, that will suppress the level of LH and FSH by suppressing the that will suppress the level of FSH and LH because it is the cyclical, or you may say fluctuating level of GnRH which keeps the LH and FSH level going. But if it is a constant supply of GnRH, then LH and FSH production will be decreased. Oral contraceptive decrease GnRH, GnRH antagonists, and GnRH agonists after GnRH receptors have downregulated. So both of these also decrease the LH and FSH production. Spironolactone and ketoconazole, they inhibit the 17 alpha hydroxylase enzyme. So basically they inhibit the production of testosterone and estrogen. Estrogen and testosterone in females and only testosterone in males. N-estrozole inhibit the aromatase, in which way testosterone won't be converting into estrogen. Finasteride inhibits the testosterone's conversion into 5-alpha reductase, which is helpful in the cases of benign prostatic hyperplasia. SERMs, specific estrogen receptor modulators, for example raloxifene, can be given in specific conditions. They can act as agonist in one place and antagonist at another place. Then we have spironolactone, flomatide, and cryo and cypoterone androgen receptor antagonists. Okay. Then we have the next thing, that is Bartholin's duct cyst. So this is the urethral meatus. Then labia minora. Outside that we have labia majora. Then cyst or abscess is found over here. Normal Bartholin gland sits down there, and this is the skiing gland. Bartholin glands are found in 4 and 8 o'clock positions at posterior vaginal introitus. Their normal function is vulvovaginal lubrication. Bartholin ducts can be obstructed by accumulation of mucus, secondary to edema and trauma. Resultant obstruction leads to proximal duct distension and cyst formation. Features are soft, mobile, non-tender, flesh-colored mass, asymptomatic, and present at birth at the base of labia majora. Treatment is asymptomatic, observation and expectant management. Symptomatic, incision and drainage, placement of word catheter. What catheter? Word catheter to reduce the risk of recurrence. Marsupialization procedure, it creates another point of drainage for the gland. Differential diagnoses include Gardner duct cyst. The Gardner duct cyst results from incomplete regression of Wolffian duct during the fetal development, appear along the lateral aspect of upper anterior vagina and do not involve the vulva. Then skin gland cysts can also be a differential and located lateral to the urethral meatus in the anterior vaginal vestibule. Bartholin gland marsupialization, incise and drain the cyst or abscess. Evert the edges of cyst or abscess and suture into the mucosal edge. So we'll keep the session till here, and we'll continue with the urinary stress urinary incontinence on the next session. Until then, Allah Hafiz, fi amanillah, and take care.